Hey everyone, welcome back to the channel. If you're a nursing student or your college students currently navigating the complexities of human anatomy and physiology, you are exactly in the right place. All right, remember, anatomy is location, 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 or structure, 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 and physiology is what? Function, function, function. So we want to know the right anatomy for us to be able to identify the abnormal. All right, that's what we call making diagnosis clinically. Today, we are about to master hematology, correct? Yes. Hematology is the clinical study of what? Of blood. So we'll discuss it with a whole lot of questions. I will encourage you to pick your pen and paper, and jot down some of these questions. Before we start, I want you to check out this, all right? This is Learner's Cruise. It's our new platform, built to help you succeed with personalized study tools. Because we notice that most nursing students, most college students, they don't fail because they didn't do enough questions. No, instead, they score very low because they studied the wrong things. So Learner's Cruise is an AI study platform that tells you what to study, why you are struggling, and when you are ready. Meaning that it gives you daily quiz that's generating AI questions for you. It gives you confidence tracking for your exam. It gives you past predictor, and also it gives you AI charts, right? Which makes everything easier for you with mnemonics, with diagrams, everything you need. And this website will be ready in the next 2 to 3 months. It is going to be very personalized to you, all right? It will adapt to your study path, whether you're a visual learner, you are an audio learner, whatever. This website is going to, take care of everything for you. So I want you guys to be the early bird, all right? We need the first 1,000 people. And these people, we're going to give them about 20 to 50% discounts, when we launch. So what I need you to do for me is to do a quick scan on your screen right now. I want you to take a quick 5-question survey, please. So just scan this QR code that you're looking at right now. Take a quick 5-question survey. It will take you less than 30 seconds. Your input helps us to build the best tools for you. So kindly scan this and join the wait list. Let's get you started, all right? Please. Extremely important. So I want you to pause the screen right now and scan this. And also, I need you to send it to every nursing student, every college student that you know, no matter the country where the person is. All right? Please. So let's jump into the main thing proper. All right? The circulatory system is a triad. What is the triad? The blood, the heart, and also the blood vessels. Very important that you know this. Today we are discussing specifically the blood, all right? And as I said initially, we're asking you a whole lot of questions. So I need you to follow along with me. These questions are important, all right? So the blood performs 3 major critical roles, which you need to know about. 1 is transportation, 2 is protection, and 3 is what? Regulation. What does it transport? Gases, nutrients. What does it protect? It protects using the immune systems, immune responses. Even clotting is part of its protective functions. And also, it regulates what? pH and temperature, thereby keeping the body at hemostatic level, balanced. They may ask you a question. Which of the following is not a function of the blood? You must know the function of the blood. Which one is not? They can tell you things, give you options like what? Initiating clotting, stabilizing pH, transporting nutrients, producing plasma hormones. Automatically, you know that transporting nutrients is a part of the blood function. Stabilizing pH is a part of blood function. Initiating clotting is a part of blood function. So automatically you know the answer. It's as simple as that. Now you need to know that adults have 4 to 6 liters of this fluid connective tissue, all right, which is the blood. Remember, the blood is one type of connective tissue, and it's about 4.5 to 5.5 times viscous as water, mostly due to concentration of what? Red blood cell. Extremely important. Now, when you centrifuge blood, all right, it separates into layers. What are those layers? If you look at the diagram very well, let me expand it. Look at the diagram very well. You see that there are 3 layers: the yellow layer, the white layer, inferior red layer. So the one at the top, that the superior one, is the plasma, about 55% of the blood. All right. Then the one below, the one that settled down, is the erythrocyte, that's the red blood cell, about 45%. Then the middle, you see what? The buffy coat, that's the whitish middle layer. And most importantly, you need to know that in the clinic, it's usually given within a range. All right. In the plasma, it's 47 to 63. Buffy coats, that's the middle layer, which is the white blood cells, and the platelets is less than 1%. All right. Then the erythrocyte is between 37 to 52%. All right. This is normal. Remember, what we are discussing is anatomy and physiology, the normal. So that when you see somebody with the plasma of maybe 70, you'll be like, oh, this is abnormal. All right. This is pathology. You feel me? Now, the normal hematocrit value also you should know. For men, it is 42 to 45% to 52%. For women, it is 37 to 48%. All right. And hematocrit is talking about oxygen carrying capacity of the blood. Extremely important that you know this. So they may ask you, which of the following is not contained in the Buffy code? Which one is not contained in the Buffy codes? So you should be able to know which elements in the Buffy codes. Remember, we talked about white blood cells and the platelets. Extremely important that you know this. So as I said initially, plasma is 90% water, but the other 10% is what matters most. All right? It contains proteins like albumin. You understand? Remember the function of albumin. Albumin is very, very important in the body because it maintains your blood pressure and fluid balance. If a patient, has a protein deficiency, for example, they can develop edema, that's swelling. Why? Because the blood loses its pulling power to keep water in the vessels. Albumin helps to keep that pulling power. So we call this drop in colloid osmotic pressure. So what helps colloid osmotic pressure is albumin. When the blood loses it, edema starts happening because the water will flow from the blood into the tissue and swell. Extremely important that you understand this. The other proteins you see, the globulins, which is about 37%. All right. Then you see the fibrinogen, which is about 4%. Fibrinogen is a very important clotting factor and also precursor to fibrin in blood clots. While globulins, we have the alpha, we have the beta, we have the gamma. They are very, very important immunological functions because you see them as antibodies, all right? They also help in transporting lipids and vitamins. They may ask you, which of the following is not normally found in the plasma? Glycogen, fibrinogen, glucose, albumin. Which one is not normally found in the plasma? See? So you start thinking about glycogen, because it's not found in the plasma. Instead, what do we find in the plasma? You can find fibrinogen. Even glucose can be found in plasma. Albumin can be found in plasma. All right. And another thing you need to also understand that if we remove fibrinogen from the plasma, we are left with serum. Extremely important that you know this. So let's talk about erythrocytes. That's the red blood cells. All right. So the erythrocytes, the oxygen carriers. Extremely important that you know this. You need to know their shape. They are biconcave in shape. All right. And they have very serious unique features like they don't have nucleus, DNA or ribosome. They lack these three things. They also don't have mitochondria. So they use anaerobic metabolism. All right. 33% of cells is hemoglobin. 280 million hemoglobin molecules per RBC. Extremely important. These are knowledge or information checks that you need to put in your head. They may ask you a question. What do erythrocytes use to produce ATP? What is your answer? Is it aerobic or anaerobic? You should know that the answer is anaerobic. Why? Because they lack mitochondria. Check it now. Now, talking about the structure of the red blood cell, since they don't have all those components we mentioned initially, we need to, we are interested in the structure, all right? And they ask a lot of questions from structure. So there are 4 protein chains, right? With 2 alpha, 2 beta, 4 hem groups. You understand? Each of them has ion, Fe2+. Then each hemoglobin carries 4 oxygen molecules. So everything is 4. This is a formula of 4? 4 protein, 4 heme, 4 oxygen. Extremely important that you know. And what is the major function of RBC? Oxygen transportation, right? It loads oxygen in the lungs and unloads, in tissues. Then carbon dioxide transport. 5% of CO2 binds to globin chains. So it picks, CO2 from, tissues and brings them to the lungs and you push it out. Also, carbonic anhydrase. Extremely important, which is an enzyme that converts the reaction between CO2 plus water. Very, very important for your pH balance. So these are the critical functions of red blood cell. How do they ask question on red blood cell? They can ask you, the heme group binds oxygen to which ion at its center? This one is very, very, very clear. The ferrous ion, that's Fe2+. In the option, they may write Fe3+. Please bear in mind that this is Fe2+, ferrous ion. Extremely important that you know this. You need to also know the normal RBC values, all right? Very, very important. For men, 4.6 to 6.2 million. For women, 4.2 to 5.4 million. That's biological males and biological females. And also the hemoglobin concentration you need to know for men and for women. And why are they always lower in women? Because androgen stimulates RBC production. You see, that's for male. And also women lose blood during their menstrual phase, all right? And also men have higher body fat percentage. How does the body know when to make more RBCs? You know, this is a very beautiful negative feedback loop, which you really should understand. So when your kidney senses low oxygen, that's hypoxemia, the kidney releases a hormone called EPO, that's erythropoietin. So what does the EPO do? The EPO travels to your red bone marrow, right? It goes to the red bone marrow and it says more cells. We need more cells. So it will stimulate RBC production in the red bone marrow. So within a few days, your RBC count rises and oxygen levels what? Stabilizes. That's exactly how it works, honestly. So this diagram helps you to understand it better, shows you exactly what I just said right now. You see, look at immediately there's hypoxemia, that's low blood oxygen. The kidney senses that, oh, oxygen is low, pushes out erythropoietin. Erythropoietin goes to the bone marrow, increases red blood cell count. Extremely important that you know this. And this is also a chart that, you know, just gives you the, if you want to jot it down, this one is exactly what we already discussed, right? So there's increased oxygen transport in 3 to 4 days immediately because of increased RBC production. So you also need to know some very important facts about the RBC, all right? Like the amount of production per second, that's 2.5 million RBCs produced per second. The lifespan, 120 days. Remember this. And development takes 3 to 5 days. They ask you these questions in exam, all right? Most importantly, you need to know the stages. There's a question on the stage I will show you. All right. Pluripotent stem cells causes the production of erythrocytes, CFU, colony forming unit, which forms the erythroblast, then erythroblast to reticulocyte, then to mature RBC. They will give you this chain, all right? Then they will tell you to arrange it properly. So you need to know pluripotent stem cell, erythrocytes, colony forming unit, erythroblast, reticulocytes, the mature RBC. Extremely important that you know this. And also you must know that regulation, which is the diagram I gave you. So in summary of red blood cells, you know, the red blood cells, they live very fast. They die young, 120 days. You know, they take 3 to 5 days to mature, and they have very specific diets and recycling program. And what is that, their diet? Iron diet, all right? Extremely important. So that throws us into how iron is essential for hemoglobin. Your body is pretty, you know, actually pretty stingy with iron because it's hard to absorb. You know, we need to consume about 5 to 20 milligrams a day, you know, but we only actually keep a fraction of that amount. Just fraction of that amount. Men lose 0.9 mg per day. Women lose 1.7 mg per day. Funny. What's the journey like when you eat something that contains iron? You know, the transformation, first of all, it starts in the stomach. Your body acid, you know, converts iron from iron 3, that's ferric, to iron 2, ferrous. So you just think about ferrous as the usable form of iron. Chicken. So you eat it as Fe3 and it converts to Fe2. Now, a protein known as gastroferritin picks it up. Let's call it the escort, all right? So the escort picks it up and takes it to where? The small intestine. Extremely important that you understand that. So ferritin takes it to the gastroferritin takes it to the small intestine. In the small intestine, it absorbs into the blood. So once it gets into the blood, then Uber, its Uber will now come and carry it. What is that Uber? Transferrin. So transferrin acts like that Uber, driving that iron to your bone marrow or muscles. Now, anything extra, right? The liver tucks it away as what? Ferritin. So that's the storage form of iron, ferritin. So if your ferritin levels are low in your lab report, your storage form is what? Low, extremely low. After 120 days, what happens to the red blood cell? You know, for 120 days, it's squeezing through tiny capillaries. So, you know, the red blood cell definitely gets fragile, you know, and it will pop. It will lyse where? In the spleen. So the spleen is the red blood cell's graveyard, all right? Remember that. But, you know, the body doesn't like waste. So what does the body do? Remember the components of the red blood cell. We talk about heme, we talk about iron, we talk about oxygen, right? Yes. So that's exactly how it's going to split. So once the macrophages digest red blood cell fragments, all right, there's globin. The globin will become what? Amino acid, and it will be reused. The iron, you know, will be removed and recycled. What happens to the heme? What happens to the heme? Look at it very well. You see? So if you look at it very well, you see the blood cells. All right, we've already removed iron. We've already removed globin. So we are talking about heme now. All right. So this is the heme there from the hemoglobin, all right, being converted to bilirubin by the liver. Then from there, it enters the bile duct, From there, it goes to the small intestine. You see the arrow? You follow the arrow, it goes to the small intestine. Then from the small intestine, some of them go to the large intestine, all right, where they form stachybilin. Some others become urinobilinogen, all right, and enters the kidney and is taken away in the kidney. Extremely important that you understand this. So the kidneys, you see yellow urine because of this what? Urobilinogen. Same thing with the intestine, all right? This large intestine, you see urinobilinogen causing the feces to become what? Brown. Extremely important that you know this. And how do you connect this thing clinically? If the liver can't process that yellow bilirubin, it backs up into the skin. It goes back into the skin. And this is what we call what? Jaundice. Eventually, it turns into urobilinogen, which is why, as I said initially, your pee is yellow, your poop is brown. Extremely important. That's how colorful biology is. Now, balance is everything in physiology. You have to be balanced. Homeostasis, all right? If you have too many or too few cells, you are in trouble. It becomes pathology. For example, when it is too many, we call it what? Polycythemia. Think about polycythemia as a traffic jam. So too many red blood cells, it makes your blood thick like a sludge, and it becomes very highly what? Viscous. And you need to know what causes it, primarily and secondary, all right? And what it can lead to. That's the risk, the dangers. Bone cancer is among the primary things, that shoots up blood count to, red blood cell to 11 million. So when you are looking at the lab result and you see 11 million for red blood cell, you are thinking about polycythemia, too much red blood cell. That's abnormality. Then, in terms of secondary causes, dehydration, living in high altitude, these are the major things that causes it secondarily. So it can actually correct itself. And because of that high viscosity, you understand, it can form blood clots and also high blood pressure, because there will be little space for others to flow. So they want to flow very fast. When you're talking about anemia is not enough red blood cells or hemoglobin. You might not be making enough. It may be as a result of your kidney failure, something, or maybe hemorrhage, bleeding, destruction, hemolytic, or it can be other things like hypoxia, all right? All these things that could lead to anemia. And anemia actually can also lead to other things. Extremely important that you know this. Just like literally gasping for air at a cellular level, your cells are just searching for oxygen. That's what anemia is about. So it leads to you being tired, fatigue, hypoxia, and all those things. Now, there's a hereditary glitch. We call it what? Sickle cell disease. Extremely important that you know it. The hemoglobin is shaped wrongly, causing the cells to turn into, rigid crescents. You just see it crescent looking, all right? So because of that crescent looking, instead of looking like a disc, that disc appearance makes them to move seamlessly, even in small vessels. But because the sickle cell disease causes them to, have a sickled appearance, that's crescent-shaped appearance, what happens? They get stuck in vessels, like a pile-up on the highway, causing massive pain and tissue damage. Now let's look at immunohematology. What you need to note is that understanding blood type is not just about anatomy and physiology. In a clinical setting, it's a matter of life and death. All right. So I want us to break this thing down. The mechanics of how your body, your body, distinguishes self from non-self in the bloodstream. That's what we are talking about right now. That's what ABO and Rh system is about. To understand blood types, we have to take a critical look at proteins involved. Think of this, proteins, the body security system. That's how I want you to understand it. Antigens agglutinogens, they are proteins located on the surface of the red blood cells. All right, they are the surface. That is your question. They act as identification tags that determine your blood type and can trigger an immune response if the body deems them as foreign material. Extremely important that you know this. Now we have the antibodies, which are the agglutinins. Remember, antigens are agglutinogens. Antibodies are agglutinins. All right? The antibodies, that is the agglutinins, these are defensive proteins found in your plasma. Antigens are located on the surface. Antibodies are found in the plasma. Antigen at the surface of your RBC. Now, these antibodies Their job is to identify and attack foreign antigen. Check it out. Leading to a process called what? Agglutination or clumping. So you need to know where is antigen found and what does it do. Antigen, they are just identification tags. Antibodies are the ones that does what? Identify and attack. So what is the golden rule? You do not produce antibodies against your own what? Antigens. If you do this, your immune system will constantly attack your own blood, all right? Which is what we call what? Autoimmune issues. There are 4 primary blood types, based on the presence of absence of A, B antigens. So antigens determine the blood type. But interestingly, while we are born with antigens, the corresponding antibodies, they don't appear in the plasma until what? 2 to 8 months after birth. Extremely important that you know this. How do I make you get this clearly? Let me look for a diagram. Perfect. Look at this diagram, right? Take a look at this. So for the type A antigens on the red blood cell, surface of the red blood cell, you see, that's A antigens, the blue one, you see, A antigens. Now, on the plasma, you will see what? Anti-B antibodies in the plasma. You need to understand this. Anti-B antibodies in the plasma. But the antigen is antigen what? A. So anytime you see antigen A, that means the person has what? Anti-B antibodies. Now, when we migrate to type B rather, type B has what? B antigens. That means the antibody in type B will be what? Anti-what? A antibody. And where is it found? In the plasma. Then look at type AB. If it is type AB, that means it has both A and B what? Antigen. So will it have an antibody? The antibody cannot form against itself. So no antibody. That's why we call it what? Universal recipient. It can receive from anybody. Now look at type O. Type O has no antigen. That's why it's O, 0. It doesn't have antigen. So if it doesn't have antigen, that means automatically it has both anti-A and anti-B what? Antibody. So they may ask you, which one has anti-A and anti-B antibody? You tell them is what? Type O. That's why type O is what? A universal donor. And you need to know that the most common is type O, and the least common is what? Type AB. That's the rarest. And remember, as I mentioned initially, antibodies appear 2 to 8 months after birth. If you have any question, put it in the comment section below, all right? I'll give you questions at the end of this discourse. More questions anyway. Now, talking about transfusion reaction. A transfusion reaction occurs when a donor's red blood cell have antigens that will react with the recipient's what? Antibody. So this causes blood to what? Agglutinate. That's clumping. You understand? And when blood clump, what will it lead to? It will lead to what? Blocking small vessels. This can lead to bursting of cells. That's hemolysis. It can also even escalate to the kidney and cause kidney failure and death. So that's why transfusion reaction is extremely important for us to watch out for. So you should remember, always match blood types and always test before what? Transfusion. Don't just transfuse. So beyond the ABO, we have the Rh antigen. That's D antigen. You understand? This is what makes your blood type either positive or negative. You see that in you write, O positive. That positive is what? Mean that you have an antigen, special antigen known as antigen D. All right? Extremely important. But if you are Rh negative, they say, you lack antigen what? D. So the key difference is that like the ABO system, anti-D antibodies are not normally present in your blood. They only form after an Rh negative person is what is exposed to Rh positive blood. It's as simple as that. Why is this important? Clinically, it's very, very important. If an Rh negative mother carries an Rh positive fetus, the first pregnancy is usually safe. Why? Because the bloodstream remains separate until birth. However, during delivery, fertile blood can enter the mother's system, causing her to produce something we call what? Anti-D antibodies. For that first pregnancy, she's fine. But in subsequent pregnancies, these antibodies can cross the placenta and attack the fetus red blood cells. And how do we prevent it? We prevent it by administering ROGAM injection to Rh negative mothers to prevent their immune system from ever learning to attack Rh positive cells. You need to understand this. Why do we give ROGAM? We give ROGAM to Rh negative. First of all, we give it to Rh negative. Why? We want to prevent immune systems from what? Ever learning to attack Rh positive cells. Let's talk about the specialized force. That's the white blood cells, all right? The white blood cells, we can also call them leukocytes or WBCs. They are primary protection against infection and cancer. They are the only blood cells with a nucleus and organelles. Very important that you know this. They will ask you in your exam, which particular one has organelles, which of the blood cells has organelles and nucleus? You are talking about what? WBCs, white blood cells. And they are divided into two major, the granulocytes and what? The agranulocytes. If you look at it very well, you see the granulocytes, you see how they have granules? You understand? The granulocytes, that's Mr. Ben, B-E-N, basophil, eosinophil, and what? Neutrophil. And agranulocytes are what? Monocyte and lymphocyte. Do you see how smooth the agranulocyte is? Very, very, very smooth. But the granulocytes, the one that has granules, they are looking rough. That's how you'll be able to identify it in case of if they give you this kind of diagram. So what do we need to know about Mr. Ben? Let's start with Mr. Ben. That's basophils, eosinophils, and neutrophils. Basophils, less than 1%. So when you look at the test reports, you should, if basophil is 1 and above, then there is something wrong with that patient. And what are you thinking about? You are thinking about histamine release. Extremely important. Histamine release. And histamine dilates vessels. Heparin also to prevent clotting. So what do? They facilitate the inflammatory response. Extremely important. Very rare. Also, E is eosinophil. Eosinophil is between 2 to 4%. If anything outside this range is abnormal. When is eosinophil produced? When there is what? Allergens. Or also when there are parasites. So you'll be seeing eosinophils, allergens, parasites. Basophils is inflammatory reaction connected to histamine heparin. Always remember this. Then they will ask you neutrophil. When do you see neutrophil a lot? Neutrophil is bacterial infection. Why? Because they help to cause what? Phagocytosis, destroy these bacteria. So that's where you see neutrophils coming out to attack. So I need you to bear in mind, Ben, basophil is usual inflammatory reactions, has something to do with histamine and heparin. Eosinophils is what? Allergens and also parasites. Why? Neutrophils are what? Bacterial infections. And neutrophil is the most abundant, 60 to 70%. That's what you are looking for. If maybe you see neutrophil like 90%, then there's a problem. When you talk about the agranulocytes, you are talking about what? Lymphocytes and monocytes, or ML. I always call it ML, monocytes and what? Lymphocytes. So since I say ML, then I'll start from monocytes. From monocyte macrophages. They are the largest white blood cells. They leave the blood to become what? Macrophages. What do? They help to clean up cells that present antigens to the rest of the immune system. You need to be able to remember this. Monocyte macrophages. What does macrophages do? They eat up, they clean up. They are the janitors of the system. Remember, this is the military. This is the defense we're talking about here. All right. Now, when you're talking about lymphocyte, that's the L. Lymphocyte makes up 25 to 33% of the entire thing. All right. So if you must look for it between 25 to 33%. Anything outside that window is abnormal. And it's very, very critical for long-term immunity. So they include T cells, B cells, you understand? And this produces antibodies, that's T and B, and also NK cells, that's natural killer cells. So you need to know the 5 of them. Neutrophils, eosinophils, basophils, or Mr. Ben. ML, monocytes, lymphocytes. Extremely important that you know this. Now let's talk about the production, lifespan, and disorders of the white blood cell, all right? All white blood cells, they originate from pluripotent stem cells. That's your exam question. Pluripotent stem cells in the red bone marrow, all right? Their lifespans vary widely. Some of them live only hours, while certain lymphocytes, can live for decades to provide what? Immunological memory. Extremely important, you need to know this. All right, what is the pathway? The class produces what? Neutrophils, eosinophils, and basophils. So anytime they tell you about Ben, talk about what? Myeloblasts. Monocytes is produced from what? Monoblasts. So monoblasts produce monocytes, which converts to what? Macrophage. Then the lymphoblasts produces lymphocytes. And the lymphocytes mature where? In the thymus. They will ask you where? In the thymus. In terms of the life cycle, the granulocytes, all right, the granulocytes, that's Mr. Ben, they live hours in the blood, to days in the tissue. So hours in the blood, days in the tissue. But the monocytes, 20 hours to years as macrophages, all right? While the lymphocytes can last for decades, they recycle themselves continuously. Very important that you also understand this. Now, what are the clinical red flags? Leukopenia, the WBC is low, less than 5,000, leukopenia. So you look at the test results. All these things is for you to be able to read the result properly. What causes leukopenia? Radiation, poisons, infection risk, anything. Then we have leukocytosis. That's when white blood cell is above 10,000. So it's between 5,000 to 10,000. You understand? Usually as a result of what? Allergies, some other things. So we have leukopenia, we have leukocytosis, and we have leukemia. Leukemia is cancer of the WBCs. All right, we have acute leukemia, which progresses rapidly and can be fatal in months. While we also have chronic leukemia, which involves slower survival rates. All right, so both of them, they cause impaired clotting and frequent infections as the cancerous cells crowd out the healthy ones. Extremely important that you know this. When a vessel is damaged, your body initiates something we call hemostasis to stop the bleeding, correct? This hemostasis relies on cell fragments known as what? Platelets. So platelets, cell fragments from megakaryocytes. Mind you, they will ask you, cell fragments from what? Megakaryocytes that live for about 10 days. They usually live for about 10 days. They have complex internal structure with granules. Extremely important that you know this, all right? So their production, we call their production thrombopoiesis, all right? Stem cell to megakaryocytes, from megakaryoblast to megakaryocytes, then from megakaryocytes to what? Platelets. Lifespan is 10 days, as I mentioned initially. A lot of them are stored in the spleen. So what's their function? I listed about 7 of them on the slide. I hope you can see it right now. Secrete vasoconstriction to reduce blood loss, form platelet plugs, clotting factors, we call them, some of them procoagulants, initiate dissolve after the clotting has been achieved. They initiate clot dissolve, attract neutrophils to mop up and monocytes, to injury sites, phagocytize bacteria, using macrophages. They secrete, great factors for vessel repair. Extremely important that you understand this. So in terms of vascular spasm, when you have an injury, what happens? Immediately, understand, vascular spasm occurs. What is vascular spasm? The broken vessel immediately constricts to reduce blood loss. You see my hand? See how I'm holding my hand like this? As I have an injury here, if I press it, they will tell you to pack an injury and press it. You are constricting, you are helping hemostasis at that moment. You are doing exactly what platelet will do for you. That is vascular spasm, so that it will reduce blood loss. Also, after that, it will form what we call platelet plug. So platelets, all the platelets come, they stick together and they expose, collagen, and each of them, they form a seal on it until it stops bleeding. Then after that, they do what we call coagulation. That's blood clotting. So this is the most effective defense. So this converts fibrinogen into a fibrin mesh to trap red blood cells. Extremely important that you understand it. And this leads us to the clotting pathway. You need to understand that the clotting pathway has an intrinsic and extrinsic part. It also have a common link. The extrinsic pathway, is triggered by factor 3 from damaged tissues. You understand? It's triggered by factor 3 from damaged tissues. And another name for factor 3 is what? Thromboplastin. So you must remember thromboplastin factor. All right, that's extrinsic, outside. And when you're talking about intrinsic, you're talking about what? Factor 12. What's the name for factor 12? Hedgeman factor. So extrinsic pathway, factor 3, thromboplastin. So for the extrinsic, 3 activates 7 activates 10. Intrinsic, 12 activates 11 activates 9 activates 8 activates 10. And you need to know the common pathway. All right, the common pathways require calcium, first of all. You need to know that, which leads to formation of thrombin, which creates the final fibrin polymer. So how does the common pathway work? Factor 10, activates the prothrombin activator, which activates thrombin. Thrombin activates fibrinogen. Fibrinogen forms fibrin polymer, which covers the injury. So once the vessel has been repaired, all right, fibrinolysis occurs. What is fibrinolysis? Clot dissolution, and this is done caused by the enzyme plasmin, which dissolves the fibrin to clear the vessel. 12, 11, 9, 8, 10, 12, 11, 9, 8, 10. So if you look at the screen right now, you'll be able to understand everything I've already said. All right, what are you seeing when there is a damage? Following the intrinsic pathway, what happens? You have to remember the number 12, 11, 9, 8. You see, 12, damage surface, factor 12 is activated. It activates factor 11. That's 12, 11. Then factor 11 activates factor 9. Factor 9 activates factor 8. You see? Now, for extrinsic pathway, if you look at the extrinsic pathway part, you are thinking of only factor 7. So intrinsic is 12, 11, 9, 8. Extrinsic is what? 7. And the two of them, they met at a common pathway, which is what? So immediately 10, they get to 10. 10 activates what? 5. And 5 activates what? 2. 2 is prothrombin. Prothrombin is converted to what? Thrombin. Active. The active one is what? All right. And thrombin now, activates, fibrinogen is 1. Fibrinogen activates what? Fibrin. And fibrin causes what? The cross-link. You see? Makes sense. So remember, intrinsic 12, 11, 9, 8. Extrinsic 7. That's it. And the two of them, they met at 10. And immediately they get at 10. 10 activates 5. 5 activates 2. All right. And prothrombin activates what? Thrombin. And thrombin, which is the active form of prothrombin, activates what? Fibrinogen. Fibrinogen is number 1. 2 activates 1. All right. Fibrinogen is now activated towards fibrin. Fibrin now causes what? The cross-link. And remember, protein C is helps to dissolve the clotting. And protein S as well. So when you get a cut, as we've been describing all along, your body doesn't just stop bleeding. It launches a high-speed chemical war, right? Okay, so first we have clot formation. We've already discussed that. It's a positive feedback loop where thrombin acts like, a gas pedal, accelerating the creation of a fibrin mesh. We already discussed the fibrin mesh, all right? So trap the RBCs, that's red blood cells. So once they plug this leak, what happens? There's something we call clot retraction. It kicks in for about 30 minutes. So I want you to think of it, as a clot tightening its belt, to pull the wound closer to each other. Trying to pull the wound edges closer to each other. That's what we call what? Clot retraction. So at the end of the day, when it is done doing this, it does what we call what? Fibrinolysis. All right? Fibrinolysis dissolves that bridge once the repair is already done. Then plasmin is the star, because plasmin, helps to clear the clots, all right? Let's call it the clot clearing enzyme. So how do you remember this? How do you remember this? Because they may ask you in your exam, what does plasmin do? What does each of them do? All right? So remember, the process of fibrinolysis starts with factor 12, all right? Factor 12 to kallikrein, then kallikrein to plasminogen to what? Plasmin. Extremely important that you understand this. That's how the plasmin is formed, and plasmin dissolves the clots. So how do you remember? Just remember it as 12 kings play piano. 12 kings play piano. Factor 12. Kings, kallikrein. Play, plasminogen, piano, plasmin. You have to play around the anatomy if you really want to understand it. So if this is possible, why doesn't, all these things are found in the blood, so why doesn't the blood just, turn into a jello inside your veins right now? Why? Think about it. So, but the point is that the body has 3 no clot zones. We call them repulsion, prostacyclin, all right, dilution, shock, and natural anticoagulants. So when we're talking about repulsion, you understand, your blood vessels are coated in what we call what? Prostacyclin. They're coated in prostacyclin. So this keeps platelets from what? Sticking with each other, all right? That's the first one. So when you talk about repulsion, think about prostacyclin. They may ask you in the exam. It stops platelets from clumping together as they do in an injury. Second one is dilution. So as long as blood moves very fast, clotting factors can't get clumpy. It's as simple as that. You understand? So this is why when you shock or maybe sitting too long is very dangerous, because it will slow down your blood, and slowing down your blood can lead to coagulation inside, clot formation. Very important that you know that. Then the third one is natural anticoagulants. Your body produces what? Heparin and other antithrombin to keep the system what? In check. So these 3 things is very, very important, and you need to put it in your head that PAD, that's PAD, pad your vessels. Pad your vessels, right? What is P? Prostacyclin, repels. A, anticoagulants, inhibit. D, dilution, in terms of flow. So pad, P-A-D, P-A-D, pad your vessels. Your vessels. So that's exactly what I have on the screen right now. Your vessels, P-A-D, P for P, platelet repulsion, prostacyclin, extremely important. So in hematology, it's always a balance between bleeding out and clogging up. Always important, all right? Something can always go wrong. Hemophilia versus thrombosis, for example. hemophilia is a genetic glitch in the clotting machinery, right? It's 3% of cases are usually a problem with type A. That's factor 8. Factor 8. Very, very important. And if you check thrombosis, right? A thrombus is a clot that is stuck. You understand? An embolus is a clot that is on the move. So remember, thrombus and embolus, there is a very big difference. All right? So thrombus is a clot that is stuck, and embolus is a clot that is what? Moving. So when an embolus, for example, hits the lungs, it causes what? Pulmonary what? Embolism. And this pulmonary embolism is a major killer in the clinical setting. Extremely important. So how do we prevent or dissolve? Right? There's a difference between preventing and dissolving. This is your one of your NCLEX exams. Preventing and dissolving. Warfarin and aspirin are for prevention. They stop clot from what? Starting. But how about if the clot has already formed? Warfarin and aspirin, they can't do anything. All right? They can't do anything. So if a patient already have a stroke or having a stroke, what do you need? You need the heavy hitters to hit it up, to break it down, right? For example, you can give TPA, that's tissue plasminogen activator. Activates what? Plasminogen to convert it to what? Plasmin, and plasmin non-dissolve the clot. Or you can use streptokinase. This is your exam. So in your exam, if they're asking you that for a patient that already have a stroke, don't give warfarin or aspirin. What you should give is what? TPA or streptokinase. Always remember that. And also, warfarin antagonizes vitamin K. So war on vitamin K. War on vitamin K. That's warfarin antagonizes vitamin K. Why TPAs clears the way. So tissue plasminogen activator, helps to clear the entire thing. So how do I get into my patient's soul? I just look for a window. And what is that window? CBC. They will ask you in the clinic, what is the clinical diagnosis, the clinical testing you need? The CBC, that's complete blood count, all right? Extremely important. So we look at the hematocrit, that's the percentage of what? Red blood cells. And also the hemoglobin, which is the oxygen carrying power of the blood. So hematocrit, percentage of red blood cells, hemoglobin, oxygen carrying power. All right. So you need to remember something, that making these cells isn't free. The body requires iron, B12, and what? Folic acid. The body requires these three things. And if any of them is missing, the whole assembly line, shuts down. All right. So how do you remember this? Just remember, I eat big fries. I eat big fries. I eat erythropoietin, big vitamin B12, and fries, folic acid. I eat big fries. You see the mnemonics? These are some of the mnemonics that you'll be getting if you are part of the people that, are going to use this our system. So please, once again, I need you to, scan this system, this QR code, fill it up. It will take you less than 30 seconds to support us, all right? So you need to know the functions of the blood, extremely important, I just want to recap very few questions because I've already treated a lot of them. So let me just recap very few questions. You need to know the functions of the blood. They're asking you which of the following is not contained in the Buffy codes. You need to know which one is not in the Buffy codes. So what is in the Buffy codes? Lymphocytes, granulocytes, agranulocytes, platelets. All these things are in the Buffy codes, but erythrocyte is not in the Buffy codes. You need to remember that. All right? And they can be asking you what's the normal hematocrit value. Remember, 37% to 52%. If you don't remember it, please go back to the slide. All right? They may be asking you which of the following is not normally found in the plasma. And what did I tell you is found in the plasma? Fibrinogen, glucose, urea, albumin. So they will give you one of them. So if you have to recognize that, oh, this particular one is not found where? In the plasma. Also, they may be asking you which of the following proteins is not usually found in the plasma. You see? Remember, albumin is found in the plasma. Transferrin is also found in the plasma. Prothrombin, fibrinogen, all these are found in the plasma normally. All right? So is hemoglobin found in the plasma? No. I think it's found in red blood cell. Yes? Yeah. So you should remember that as well. And what is the most abundant protein in the plasma? Albumin? Yes, albumin. So remember that. What if they ask you the difference between serum and plasma? For example, they say serum is essentially identical to plasma except for the absence of what? What is lacking? What is lacking? Fibrinogen. Remember that. I mentioned it when I was discussing. Do you remember this diagram? What if they ask you, where does myeloid hematopoiesis take place in adults? Where? Is it in the thymus? Is it in the spleen? Is it in the red bone marrow? Is it in the yellow bone marrow? Is it in the liver? Just telling you where does the red blood cell form. And that is the red bone marrow, all right? Not yellow bone marrow, red bone marrow. Do you still remember what I told you about viscosity? Viscosity of blood is due more to the presence of what? red blood cells than any other factor. You understand? So viscosity is caused as a presence of red blood cell. I mentioned it initially. Can you still remember the functions of erythrocytes? That's red blood cell. They transport oxygen and what? What else do they transport? Transport specifically in terms of transportation. If you look at it very well, I mentioned that they transport what? Oxygen and what? Carbon dioxide. And in terms of this transportation, how do they transport most oxygen? What does the oxygen bound to? To the hem groups in the hemoglobin, correct? Yes. So the oxygen bound to the hem groups. What would happen if all the hemoglobin contained within the red blood cells become free in the plasma? It's as simple as that. Like, it will increase blood colloid osmotic pressure. It's as simple as that. It would significantly increase blood colloid osmotic what? Pressure. So if there's an increased production of EPO by the kidney, what will it lead to? Remember, it will lead to increased blood osmolarity. It will lead to increased RBC production. It will lead to increased blood viscosity. It will lead to increased what? Hematocrits. So you should be able to guard against that question. You understand? And increase the erythropoietin output by the kidneys would lead to all of the following, right? They can say all of the following, except. So you should know what they can lead to so that you'll be able to know the one that they cannot what? Lead to. Can it lead to hypoxemia? No. How? Because there will be a lot of oxygen available for it. So where do most of the red blood cells die? Spleen and liver, right? Right? Yes. So this is just a recap. I've already mentioned all these things. Which of the following would not lead to polycythemia? Which of the following would not lead to polycythemia? I mentioned what leads to polycythemia. We have the primary, we have the secondary. So you need to know the primary and the secondary so that you'll be able to know which one doesn't lead to what? Polycythemia. All right? Which of the following is most likely to cause anemia? You should know the causes of anemia. All right? Inadequate production, bleeding, hemolytic, and others. All right? So if somebody tell you high altitude, can it cause anemia? No. Air pollution, other than by carbon dioxide? No. Smoking? No. Any factor that creates a state of hypoxia? No. But if you tell me something like kidney disease, of course. Because if kidney, stop producing erythropoietin, then what will go to the bone marrow and ask it to produce more blood? Nothing. So it becomes a problem. That's why if you see people that have kidney problem, they are always anemic, even if they are doing dialysis, because dialysis will not give you new blood. All right. And if they ask you which of the following is not true of a patient with anemia, which one is not true? You should know which ones are true. So when somebody have anemia, how does the person look? They are lethargic. Their blood osmolarity is reduced. Their resistance to blood flow is reduced. You understand? More fluid transfers from the bloodstream into their intercellular spaces. You understand? But if you tell me, somebody that have anemia, their blood viscosity is increased. No, viscosity means it's moving slow like snail. No. If we have anemia, it should be moving faster. What is the final product of the breakdown of the organic non-product moiety of hemoglobin? Just asking you, hemoglobin, what is the final breakdown? Is it biliverdin? Is it globin? Is it hem? Is it iron? Or is it bilirubin? The answer is bilirubin. You cannot forget. You cannot miss something like that. They may ask you this question in different formats. All right? And vitamin B12 deficiency will cause pernicious anemia. Vitamin B12 deficiency will cause pernicious anemia. As a person with type A blood can easily donate RBCs to someone of type AB, right? Yes. And can receive red blood cells from someone of type O. O is a universal donor. It gives everybody. And what of a person with type AB blood? What does the person have? A person with type AB blood, I mentioned it, type A has antigen A, type B have antigen B, type AB have antigen AB. You need to know what they have, all right? So a person with type AB blood has antigen A and B, doesn't have an antibody, all right? Very, very important that you know that. And this question is saying, why a pregnant Rh negative female given an injection of Rh immune globulin? Why do we give that injection? You understand? So you need to remember, as I mentioned initially, about erythroblastosis fetalis that usually happen, all right? The woman will start giving birth to stillbirth from the second pregnancy. So why do we have to give them injection? That injection is ROGAM injection. Why do we have to give that injection? We give that injection, because the antibodies in the injection bind fetal red blood cell antigens. So it binds to it. So they cannot stimulate the mother's immune system to produce anti-D antibodies. Because what really happens, this mother she does not have an anti-D, correct? So, but her child is positive. So her child has anti-D. So because of that, her body will start her immune system will start producing anti-D antibodies. So when she gives birth to she's pregnant for another child, those anti-D antibodies will kill that child or they will damage that child. So we give that injection to stop the fatal red blood cell, because it's usually the fatal red blood cell, that's the fatal red blood cell antigens that stimulates the mother's body immune system to produce anti-D. So that injection will hold that fatal red blood cell antigens so that they will not stimulate the mother. They ask you a question: universal donor of the red blood cell, but not necessarily plasma, is blood type dash. Universal donor of anything is what? O, please. O, Rh negative. Usually O, Rh negative. They can tell you O, Rh positive. Please don't choose O, Rh positive. It's O, Rh negative. An individual has type B, Rh positive blood. The individual has dash antigen and can produce anti-dash antibody. So an individual that has a type B definitely has B antigen. And the person have Rh positive blood, meaning that he has what? D antigen as well. And can produce anti-what? Anti-what? A antibody. Check it out. The main reason why an individual with type AB, Rh negative blood cannot donate blood to an individual with type A, Rh positive blood is because it's as simple as that. Because of anti-B antibodies in the recipient. That anti-B antibody in the recipient will agglutinate RBCs of the what? Donor. Simple. Because he has the antigen A. Extremely important that you know this. Antigen B rather. Extremely important that you know this. All right. Now, that question I asked initially. A female's first pregnancy is normal, but that second pregnancy results in hemolytic disease of the newborn. The second child needed a transfusion to completely replace the agglutinating blood. The mother is most likely type what? Type A, Rh negative. And those children are type B, Rh was positive. It's as simple as that. I hope you understand that question. If you don't understand it, pause the video and go back to it, all right? So that you'll be able to understand it better. And what is the least abundant of the formed elements? Remember, it's basophil, because I said in the clinic, we are looking for basophil. Normal basophil is less than 1%, all right? If it's more, you suspect something. And their most abundant agranulocyte is what? Lymphocyte. Now, some people are going to choose neutrophil. Neutrophil, right, is not agranulocyte. They specifically say the most abundant agranulocyte. It is lymphocytes. Remember, agranulocytes is monocytes and lymphocytes. You understand? And lymphocyte is bigger than monocytes. Simple. But if they ask you the most abundant of all of them, you can't start talking about what? Neutrophil. So you have to be focused so that you don't make a mistake. And what increases in response to bacterial infection? Neutrophil. You know that this already, I guess. Which of them secretes histamine and heparin? Basophil. Basophil. Inflammation. Remember, basophil. Inflammation. Histamine. Heparin. Eosinophil is talking about what? Parasites, phagocytizing, allergen. You understand? Parasitic infection, allergies. Why neutrophil is abundant, as I mentioned, which is what? Bacteria. Lymphocytes is talking about what? Immune cells, like, that helps in fighting what? Cancer. Why monocytes is usually what? For phagocytosis, because it forms what? Macrophages. So any question they ask, you'll be able to answer it properly. What if they ask about leukopoiesis? Leukopoiesis begins with the differentiation of what? Hematopoietic what? Stem cells. Hematopoietic what? Stem cells. It is there looking at you. All right? So you make sure you don't get it wrong when you see it in your exam. Lymphocytes. How long can lymphocytes survive? Decades. Lymphocyte can survive what? Decades. Tell me about leukocytosis. All right? A patient is diagnosed with leukocytosis if they have more than how many WBCs? 10,000. Leukocytosis, 10,000. They can ask you, the cessation of bleeding is specifically called dash. Specifically. Option, vascular spasm. Second option, homeostasis. Third option, hemostasis. Fourth option, platelet plug. Fifth option, coagulation. Please, the answer is what? Hemostasis. Blood. Blood. Stasis, stopping. Hemostasis. Look at this question. They said, what is the function of thromboplastin in hemostasis? Right? It initiates what? The extrinsic pathway of coagulation. So you need to know about hemostasis. Thromboplastin, rather. When a clot is no longer needed, fibrin is dissolved by what? What dissolves fibrin? You look at fibrinolysis. I said fibrinolysis. Fact 12, kallikrein, plasminogen, plasmin. So it's dissolved by what? Plasmin. Don't pick kallikrein. Don't pick anything. Pick what? Which of the following does not prevent the spontaneous formation of clots? So you need to know what helps prevent spontaneous formation. So you think about smooth prostacyclin-coated endothelium of the blood cells under what? Platelet what? Repulsion. We have the dilution of the thrombin when blood flows at normal rate. We have the presence of antithrombin in plasma. We have the presence of what? Heparin in plasma. Can you remember when I was trying to explain the difference between thrombus and embolus? Now look at this question. Most strokes and heart attacks are caused by the abnormal clotting of blood in an unbroken, and moreover, a piece of the dash clot may break. So when it's broken, it's what? Thrombus. So, but when it breaks loose and begins to travel in the bloodstream, it becomes what? Embolus. Traveling embolus, enroutes, embolus, enroutes, embolus. And when you are talking about the production of the clotting factors, it is in the liver. So please, I want you to snap this and send to your friends. I'll put the link in the comment section in case if you want to prefer copying the link. Copy the link. I want you to do this survey. I want you to put your email address so that you'll be among the first 1,000 people that will be using the system. In case of